is capable of transmitting virus for the rest of its life. And so the mosquitoes which are potential carriers of the virus must be killed before it would bite and infect humans. So this is the mosquito to human transmission. The time it takes from ingesting the virus to actual transmission to a new host is termed the extrinsic incubation period. It takes about 8 to 12 days when the ambient temperature is between 25 to 28 degrees Celsius. Variations in the extrinsic incubation period are not only influenced by ambient temperature, but there are factors such as the magnitude of daily temperature, fluctuations, virus genotype, and initial viral concentration can also alter the time. So, for the human to mosquito transmission, so mosquitoes can become infected from people who are viremic with the dengue virus. So, people, this can be so those who are individuals who are viremic with the NV are those who has symptomatic dengue infection, or those yet to have a symptomatic infection, the pre-symptomatic, or those who are no signs of illness, the asymptomatic ones. So human to mosquito transmission can occur up to 2 days before someone shows symptoms of the illness and up to 2 days after the fever has resolved. The risk of mosquito infection is positively associated with high viremia and high fever in the patient. Most people are viremic for about 4 to 5 days, but it can last as long as 12 days. However, high levels of the DNV specific antibodies are associated with decreased risk of mosquito infection. So when it is on the period wherein there are high levels of the dengue virus antibodies, then there is decreased risk of um, transmission from human to mosquito or mosquito infection. There. So other mode of transmission is the possibility of maternal transmission from a pregnant mother to her baby, as shown in some evidence. The vertical transmission rates appear low, though, and the risk of vertical transmission seem to be linked to the timing of the dengue infection during the pregnancy. So, when a mother does have a dengue virus infection when she is pregnant, the babies may suffer from preterm birth, low birth weight, and fetal distress. So, moving on, dengue causes symptoms ranging from asymptomatic to mild febrile illness to critical cases of multi-organ failure. In these cases of severe infection, patients exhibit blood plasma leakage, hence the term dengue hemorrhagic fever. Symptoms usually last for 2 to 7 days after an incubation period of 4 to 10 days after the bite from an infected mosquito. It can affect infants, young children, adults, and seldom causes death. Let's now review on the case classification of dengue. So dengue is categorized as dengue without warning signs, dengue with warning signs, and severe dengue. So probable dengue is when a patient who resides or has recent travel or activity in a dengue area uh, present with present no um, with any of the of the following symptoms, such as the headache, body malaise, myalgia, arthralgia, retroorbital pain, anorexia, nausea, vomiting, diarrhea, flushed skin, rash, it may be petechial or Hermann's, and tourniquet test positive. And a laboratory test which shows leukopenia by CBC with or without thrombocytopenia and or dengue NS1 or IgM antibody test positive. It is confirmed dengue when there is positive viral culture isolation and PCR. It becomes dengue with warning signs when it is associated with the following warning signs: abdominal pain or tenderness, persistent vomiting, signs of fluid accumulation, mucosal bleeding, impaired consciousness, restlessness, liver enlargement, and with laboratory showing increase in hematocrit with or without decreasing platelet count. Then it becomes severe dengue when there is severe plasma leakage leading to shock or dengue shock syndrome and to fluid accumulation with respiratory distress, such as that with pleural effusion. And or when there is severe hemorrhage, and or when there is severe organ impairment, such as when there is liver involvement manifesting as elevation of AST or ALT more than 1,000, when there is neurologic signs and symptoms such as seizures, impaired consciousness, when there is heart involvement manifested as myocarditis, or kidney involvement such as renal failure. So a patient can present initially as dengue without warning signs or with warning signs, later on progressing to severe dengue, or um, initially presenting as severe dengue already. So understanding dengue fever entails understanding the course of its illness. After the incubation period, the illness begins abruptly and will be followed by three phases in the following order: febrile, critical, then recovery phase. The first phase is the febrile phase, wherein there is mainly fever, of course, and symptoms. Other symptoms may also occur, and usually lasting 2 to 7 days. Monitoring for warning signs is crucial to recognize its progression to critical phase. In this phase, mild hemorrhagic manifestations may be seen, such as petechiae and mucosal membrane bleeding, such as that in the nose and gums. The earliest abnormality in the CBC is progressive decrease in total white cell count, which should alert the physician to a high probability of dengue. So here are the clinical signs and symptoms during this phase, which were already mentioned earlier. Here are some of the different presentations of rash reported in dengue: diffuse exanthematous rash and the petechial rash. The next phase is the critical phase, when defervescence occurs usually on day 3 to 7 of illness. The temperature drops to 37.5 to 38 degrees Celsius or less and remains below this level. Around the time of defervescence, patients can either improve or deteriorate. So those who improve after defervescence have dengue without warning signs. But those who deteriorate, manifesting with warning signs, could be classified as dengue with warning signs or even severe dengue already. So warning signs are the result of a significant increase in capillary fragility. It marks the beginning of the critical phase. A period of clinically significant plasma leakage usually lasts 24 to 48 hours. As mentioned earlier in the lecture, here are the warning signs and are usually noted in this phase, the critical phase. And some may deteriorate to severe dengue, may be presenting with shock, which occurs when a critical volume of plasma is lost through leakage, often preceded by warning signs, and the body temperature may be subnormal when shock occurs. So it is important to check if there is cold, clammy extremities. With prolonged shock, there is consequent organ hypoperfusion, leading to progressive organ impairment, metabolic acidosis, and disseminated intravascular coagulation. In turn, it leads to severe hemorrhage, causing the hematocrit to decrease in severe shock. And instead of Leukopenia, usually in this phase of dengue, total white cell count may increase in patients with severe bleeding. This could be due to massive inflammatory response when the severe inflammation associated with a vascular leakage, hemorrhage, or and shock prompts the immune system to release white blood cells or neutrophilia. The last phase is the recovery phase when there is gradual reabsorption of extravasated fluid from the intravascular to the extravascular space by way of lymphatics, and it takes place in the next 48 to 72 hours. So, in this phase, it is when patients' general well being improves, and the hemodynamic status stabilizes, and diuresis follows also. So some may have the classical rash, described as isles of white in the sea of red, or the Herman's rash, and it is important to assure the family and patient at this time. Also, hematocrit stabilizes or may be lower due to the dilution effect of reabsorbed fluid, and white blood count usually starts to rise soon after defervescence, and normalization of platelet count would typically occur later than that of WBC count. So it is the WBC count that increases first, then the platelet count trend or level follows. So here are pictures showing the Isles of White in the Sea of Red. So important to note the possible clinical problems encountered in relation to the phases of dengue. So in febrile phase, it is dehydration, wherein high fever may cause febrile seizures in young children, and would also cause neurological disturbances. In critical phase, shock from the plasma leakage, severe hemorrhage, organ impairment, as mentioned earlier, are usual are the usual clinical problems encountered. And in recovery phase, hypervolemia, only if intravenous fluid therapy has been excessive and or extended into this period. So this is a graphical summary of the course of dengue illness. Temperature is highest during febrile phase, of course, and goes down to normal in the critical and recovery phases. Hematocrit increases and platelet trend decreases during the critical phase, and reverses when it is in the recovery phase. Take note that the IgG dengue antibody test can still be detected in the recovery phase. So this is end of part one. Are you still okay? I think. So that's we've tackled on the background before we go to the diagnostic and treatment recommendations. So I think we're still okay. Still 30 minutes. So I think your attention span is still there. So let's proceed. So the following are the diagnostic recommendations emphasized in the latest DOH approved CPG guidelines on dengue. So let's first tackle on the points that were emphasized on the latest DOH approved CPG guidelines. So first, so among those with suspected dengue infections, it is recommended to use dengue NS1 rapid diagnostic test or RDT, and reviews showed that it is most useful in individuals presenting within 3 days of symptom onset and in patients with no previous history of dengue infection. So this is, I think, what this is somehow not emphasized in the previous CPG. So in the latest, it is being really emphasized to do the dengue NS1 RDT. Since in the definition case, actually, um, probable dengue is with or without positive dengue NS1. But in the latest, here in the CPG, they really recommend this test for early detection and somehow um, more prompt intervention. So again, going back, no, so the dengue NS1 RDT is most useful within 3 days of symptom onset, and for those with no previous history of dengue infection. So this is because NS1, which is a non-structural glycoprotein, is produced by dengue virus during its replication process, so early in the illness, and can be detected in the serum starting 1 day before the onset of symptoms until at least 5 to 7 days after symptoms. So this glycoprotein, so a protein, serves as an antigen during acute phase of illness wherein it is still freely available in the serum since there is no sufficient antibodies yet produced that would complex to the antigen or protein. So also it is most useful for primary infection since if there is already history of dengue infection, meaning there is already antibodies produced from the previous infection. And so in secondary infection, antibodies to the same dengue virus serotype is more readily available during the acute stage of illness. So the antibodies right away complexes to the antigen, making it not readily available compared to those with the first infection. So I hope you got it. Then also based on studies, the pooled sensitivity of NS1 RDTs was moderate at zero point 0.7, while the pooled specificity was high at 0.96. So this means that a positive NS1 result confirms dengue infection, but a negative result does not exclude the diagnosis. So the DOH strongly recommends the use of NS1 RDT because of the practicality and usefulness of NS1 for the early diagnosis of dengue infection, especially for areas that have no access to standard diagnostics like RT-PCR. And using this test, the NS1 RDT, facilitates necessary early intervention. Indeed, clinical examination complemented with the use of simple and rapid diagnostic tools is the cornerstone to the recognition and early diagnosis of dengue. Though virus isolation and RT-PCR are the gold standard for dengue diagnosis, with the ability to determine the circulating dengue serotypes, there are limitations on their use, such as timing of the test, and availability only in centers with specialized laboratory equipment, um, the requirement on special storage temperatures, as well as trained personnel, and it is more expensive and have a longer turnaround time. Hence, not practical and will not help in early timely intervention, unlike when using NS1 RDT, especially in our setting in the Philippines. So again, dengue NS1 RDT has high sensitivity for primary infections while low sensitivity in secondary infections. As previously mentioned, the phenomenon of lowered NS1 antigen detection in secondary infections is caused by NS1 antigen complexing with anti-NS1 antibodies, resulting in an inability of the NS1 antigen RDT to detect complex NS1 antigen. So since the NS1 antigen is already complex to the antibody, so it's not freely available in the serum. So review on studies showed highest sensitivity for infections caused by the DNV3 and lowest for DNV4. And the brand which showed highest sensitivity was that of dengue day 1 test, J. Mitra and Co. India kits with high sensitivity at 0.94. And here are the prices. Dengue day 1 is the um, less expensive. As you can see, no, the cheapest is at 202 to 298 pesos. The dengue day 1 test, which which is also the one who has highest sensitivity. And as you can see, the dengue NS1 RDTs are less expensive than the PCR, may it be in the government or in the private hospitals. So, furthermore, it is also recommended to use combined dengue NS1 IgG, IgM, IgG RDT. So there is also a combined assay. It is recommended among patients with suspected dengue infection who present for more than 5 days already from onset of symptoms, with both sensitivity and specificity high at 0.86 and 0.94 respectively. So the accuracy of combination assays for dengue NS1 IgM IgG had high sensitivity and specificity. The NS1 alone are most sensitive when collected earlier in the disease course, as mentioned earlier, and gradually decrease thereafter. However, when combined with the serology on IgM and IgG, the pooled sensitivity remains high even beyond day 3 of illness. So NS1 alone, high sensitivity usually 3 days or less of illness. But when combined, the sensitivity is still high even beyond day 3 of illness. So based on the reviews, IgM, IgG, RDTs are more accurate when used for secondary infections and later in the course of illness, more than 5 days. And the test kit brands that is showing more accuracy is the Pan Biodengue, Duo, Merlin, and Biocinex. So the scientific explanation on this is that IgG and IgM are antibodies which are produced later in the course of illness during the adaptive phase of the of our immune system responding to any microbe or virus. And when there is re-exposure of the same serotype of virus, it means that there was already antibodies produced. And there is also memory B cells that would enhance the reaction of immune system to be greater and earlier than expected, compare when it is during primary infection. Hence, IgG IgM is accurately detected more on secondary infections and later in the course of illness. Mm, for there in terms of cross reactivity with other flaviviruses such as malaria and leptospirosis have been reported when testing anti-DENV IgM. However, in a study by Zhang et al. Evaluating the Umasis, CARE US, and SD Bioline NS1 IgM IgG-RDT kits, so the SD Bioline IgG kits showed no cross-reactivity with chikungunya virus infected serum, while all these three kits showed no cross-reactivity for the NS1 IgM kits, no cross-reactivity with chikungunya virus infected serum. And UMACIS and CARE-US for the IgG test kits showed cross-reactivity at 80% and 73% respectively. So, therefore, for confirmation of dengue infection, IgG alone is not recommended without additional NS1 IgM antibody testing, and evaluation for other flavivirus infections as differential diagnosis is also recommended. So, on the impact of prior dengue vaccination, such as Dengvaxia, it may confound the interpretation of dengue IgM and IgG serologic tests. So, in fact, in a phase 2B RCT on a tetravalent dengue vaccine, there was high false positive rates when IgM IgG serologic tests were done in those with vaccination after 2 months. So, such study shows the need to exercise caution when using the serologic tests on IgG IgM in the diagnosis of dengue among previously vaccinated individuals. So, the timing of disease presentation, results, and pattern of um, ancillary tests such as the CBC in relation to fever and other symptoms, and dengue NS1 test results can help in the interpretation of dengue serologic test results in the context of having prior dengue vaccination. So going clinical is still important. Here are the prices of the NS1 IgG IgM kits, which are way cheaper than the dengue virus culture or RT-PCR, which are the gold standard for diagnosis. So still they are cheaper. And the dengue RDTs in combination kits, NS1 IgM IgG or IgM IgG are readily available in laboratory centers. None is approved by the Philippine FDA to be self-administered nor for home use, only for readily available in laboratory centers. Another diagnostic recommendation is that among adult and pediatric patients with dengue fever, any of the following is clinical signs is a basis for in-hospital management. So for the signs and symptoms, vomiting, persistent persistent vomiting, abdominal pain, tenderness, lethargy, restlessness, mucosal bleeding, impaired consciousness, hepatomegaly, and acute renal failure. And for comorbidities, presence of obesity, pregnancy, and other comorbidities involving cardiac, renal, hematologic, or pulmonary, and any one of the following laboratory parameters: increase in hematocrit with or without decrease in platelet count, elevation of transaminases, impaired PT or PTT, and presence of thrombocytopenia. And in a subgroup analysis, particularly on prognostic factors for pediatric populations, the strongest predictor for severe dengue was shown to be neurological signs in varying manifestations of decreasing levels of consciousness. And unlike in adults, it was only in the pediatric population where the presence of PTK showed an association with severe dengue. Indeed, accurate prognostic estimation by being able to identify the mentioned signs and symptoms is important for effective clinical management to prompt intervention for high risk of severe dengue. Identifying predictors of progression to severe disease is essential for triage and early management and serves as a defining criterion for classifying severe dengue according to the 2009 WHO dengue classification. So aside from the clinical criteria, there are factors that impact disease outcome. One is chronic use of anticoagulants. patients on long term anticoagulant therapy require close monitoring and specialized care in a hospital setting due to the potential risk of bleeding complications associated with dengue. Also, significant comorbid illness impact the disease outcome. Patients with underlying medical conditions such as cardiovascular disease, respiratory disorders, or immunosuppression may be at higher risk for severe dengue complications and may benefit from hospital based management. With or without warning signs, the following factors also impact disease outcome and should be considerations for in hospital management. The limited access to the nearest healthcare facility, um, or those living in remote areas may face challenges in accessing timely medical care. And so hospitalization may be considered to ensure close monitoring and prompt intervention if needed. Then, for those patients who live alone and lack adequate support or caregiving resources, may also require hospitalization to ensure their safety and access to medical assistance. These social factors, along with clinical assessment, can help healthcare providers make informed decisions about the appropriate level of care and management setting for patients with dengue fever. Lastly, on the diagnostic recommendations from the latest CPG approved by DOH, for outpatients with suspected, probable, or confirmed dengue, initial CBC should be done in the first visit to establish baseline hematocrit and platelet count. Then daily CBC determination is done then for disease monitoring. The subsequent CBCs are done based on clinical course or presentation, which includes consideration on the volume status, urine output, temperature, ability to tolerate feeding, and the presence of warning signs. Then the CBC monitoring will be discontinued once the patient is in the recovery phase, wherein there is increasing platelet trends, while patient is 48 hours febrile already, with adequate urine output and improved sense of well-being and with good appetite. Indeed, the key to good clinical outcomes of dengue is early detection and a clear understanding of the clinical problems that may arise during the different phases. The CBC parameters such as hemoglobin, hematocrit, WBC count, and platelet counts are dynamic throughout the course of dengue infection. Although certain although these parameters have certain patterns observed, especially in relation to fever. Notably, these are the profound hemoconcentration and thrombocytopenia observed usually before the lysis of fever and onset of shock. And because thrombocytopenia and hemoconcentration have always been a common finding in dengue, serial daily platelet counts at the early stage of disease may help identify patients who are likely to develop shock. The frequency of doing CBC is usually based on the clinician's discretion, since the advantage of doing more frequent CBC, such as like more than once a day versus daily CBC monitoring in improving clinical outcomes, remains to be established. Currently, there are no ongoing studies or clinical trials comparing the effects of different schedules of CBC determination among patients with dengue infection. Moreover, none of the observation studies reported on the incidence of adverse events associated with frequent CBC monitoring, such as rates of local inflammation, site bleeding, pain, and site infection. But in one small case series, the potentially most serious adverse events associated with venipuncture relate to nerve injury. Though studies are still ongoing and there are research gaps on this, CBC is widely available in most hospitals in the Philippines, hence frequent CBC monitoring and may be done in dengue patients. Let me excuse for a while. Are you still okay up to this time? I think it's 1 hour and 30 minutes already. So I think most of you are still up. So let's move on to the treatment recommendations emphasized in the newly approved CPG of dengue. So among patients with probable or confirmed dengue fever, use of oral rehydration solution to prevent poor outcomes is recommended. The pathophysiology of dengue illness proceeds via two key processes: increased vascular permeability leading to vascular leakage, and abnormal homeostasis due to vascular changes and thrombocytopenia. Consequently, interventions directed to address these processes would prevent complications like congestion and organ hypoperfusion. Hence, replacement of fluid losses is a priority in the management of dengue. However, the plasma leakage is transient and lasts only for 24 to 48 hours and should be taken in consideration so as not to cause fluid overload, which is the common clinical problem during recovery phase. So, on the efficacy and safety outcomes of oral rehydration therapy versus intravenous therapy, there is shorter hospital stay for patients given oral hydration compared to intravenous therapy. For laboratory parameters such as mean pulse pressure, hematocrit level, and mean platelet count for 7 hospital days, there is no significant difference, and all patients survived in the study. And in terms of adverse events, there was less pulmonary edema or effusion, less gallbladder swelling, and less ascites or use of parenteral furosemide in the ORS group. An oral rehydration salt solution costs about 15 to 17 pesos per sachet in pharmacy. So I think it's not that expensive. And the DOH drug price index priced it at 3 pesos per sachet. One sachet is dissolved in 200 ml of water, and where is that? 5 sachets dissolved in 1 liter of water will make the following um, composition of electrolytes and osmolarity, which is consistent with the latest WHO and UNICEF recommendations of reduced osmolarity ORS. So next is on acid suppressants. Among patients with confirmed or probable dengue fever, the recommendation was against the use of acid suppressants for the prevention of gastrointestinal bleeding or abdominal pain, primarily due to the lack of evidence of its efficacy and based on the pathophysiology of how abdominal pain precipitates in dengue patients, wherein abdominal pain is due to vascular leakage leading to organ hypoperfusion, fluid retention, causing organ congestion, or abnormal hemostasis for the bleeding. Hence, the use of acid suppressants will not directly relieve abdominal pain. Also, the use of PPI and H2 receptor antagonists, H2RAs, may provide clinicians a false sense of security in managing the abdominal pain, leading to laxity in disease monitoring. And on top of all these, because of the possible adverse events or reactions following omeprazole use, such as hypersensitivity, anaphylaxis, bacterial translocation, or diarrhea. Thus, the recommendation to avoid doing more harm than benefit. So, the DOH is against the use of acid suppressants. On herbal medicines available locally, so for patients with confirmed dengue infection, giving papaya, carica papaya leaf extract or juice preparations as a supplement to standard therapy is suggested. But against in giving tawa-tawa, the Euphorbia hirta preparations, as well as the guava or Psidium guajava preparation, as supplement to standard therapy due to insufficient evidence. There is lack of clinical trials in humans. On 11 RCTs, the papaya leaf extract show benefit in terms of preventing severe dengue by increasing platelet counts by day 5 of treatment and decreasing duration of illness, as well as decreasing fever duration, as well as decreasing length of hospital stay, and reducing the risk of requiring platelet transfusion. There is no significant difference in terms of hematocrit values, risk of developing pleural effusion, and inconclusive results on adverse events. So that were the points emphasized in the latest dengue CPG approved by DOH. There are still a lot which was not mentioned in the latest CPG but remains to be essential and only found in the previous CBG. So I think it is still worth to know it. So, but before we proceed, do we need an icebreaker? So I have a 3-second icebreaker here. So let's now go to the main um, important thing, no, in dengue, the treatment guidelines. So let's um, have a review on it step by step. So here is the stepwise approach to management of dengue. It begins with the overall assessment, which includes the history, PE, and laboratory investigation, which helps us in the diagnosis and assessment of disease phase, the febrile, critical, or recovery and severity, with or without warning signs, or severe dengue. Being able to classify the case will help us the kind of management to give the patient. So treatment is according to the type of patient or classification phase. classification of the case. So, in the history, it is important to ask the following: onset of illness, oral intake, status, presence of the warning signs, and relevant ancillary histories, such as history of travel or where the patient resides. And PE should include the following: the hydration status, hemodynamic status, PE findings that will help us detect organ involvement, rash, bleeding signs, and especially in pediatric population, the tourniquet test. So this is the table showing the parameters to assess for the hemodynamic status, which includes the sensorium, capillary refill time, extremities, peripheral pulse, heart rate, blood pressure, and respiratory rate. Here are the criteria for the stable condition, for the compensated shock, and the hypotensive shock. So then the investigation. So after the history PE, then the investigation, as previously discussed already on the points being emphasized in the DOH CPG guidelines. And the step two in the management is the assessment, formulation of the assessment based on the data gathered in history, PE, and labs. And step three, the decision of type of management, is based on the assessment from step two. The decision may be to send the patient home, to admit for in hospital management, or to refer urgently as emergency treatment. So, those who are eligible to be sent home are those able to tolerate adequate volumes of oral fluids and pass urine at least once every 6 hours and do not have any warning signs, particularly when fever subsides. As part of outpatient care, patients should be educated to watch out for defervescence and warning signs. They should be reviewed daily for disease progression. And those with stable hematocrit can be sent home with advice to return immediately if warning signs develop. These patients being sent home should also be advised to do hydration orally by taking ORS containing the 45 to 60 millimoles per liter with reduced osmolarity. It can be given based on weight following this Ludan method. Take note that sports drink should not be given due to its high osmolarity, which may cause more danger to the patient. High osmolarity or hyperosmolarity is dangerous for dengue patients because it exacerbates the dehydration and vascular leakage that characterize the disease critical phase. Home card can be given stating what to do, such as adequate bed rest and fluid intake, paracetamol as needed for fever, tepid sponging to control fever and avoid dehydration, and education on eliminating mosquito breeding sites around the home since they can be the source of human to mosquito transmission and thus spread of the dengue virus in the area. So home card also includes what should not be done, such as do not take NSAIDs, such as aspirin, ibuprofen, or naproxen, because it increases the risk of severe bleeding and hemorrhagic complications. And also advise that antibiotics are not necessary for a viral infection such as dengue fever. So before sending patient home, it is very important to educate the patient on the warning signs and signs of severe dengue. And once noted, they should be informed or informed that they should return or go immediately to the hospital. While some may be sent home, some should be referred for in-hospital management based on the following criteria, which were already discussed earlier. So those with warning signs, coexisting conditions, and those with social circumstances. Those admitted may be dengue without warning signs, but has comorbidity or social factors that permit for hospital management. For these patients, oral fluids are still encouraged, but if not tolerated, then IV fluid should be given. NSS or Ringer's lactate, plain or with dextrose at maintenance rate, um, can be given. So this table shows how to calculate the maintenance rate of the IV fluid infused for the dengue without warning signs. For example, in a patient with 22 kilogram body weight, so for the first 10 kilogram body weight, it is computed as 4 ml per kilogram per hour, and the next 10 kilogram, it is computed as 2 ml per times 10 kilogram per hour. Then multiply 1 ml by every kilogram after the first 10 kilograms. So for this patient, there are 2 kilograms after it. So after the 20 kilogram, 22 man ang patient. So 1 ml times 2 kilogram per hour. Then add all the products to come up with the maintenance rate as ml per hour. So for this case, the maintenance rate of the IVF is at 62 ml per hour or 15.5 drops per minute. This is a table showing a summary of the hourly maintenance fluid for obese or overweight patients. So if the patient is 80 kilogram, then the maintenance rate is 120 ml per kilogram. So for the previous patient, the patient was about 22. So we're still correct. It's about 60 ml per hour. So this is just a short table that gives us a shortcut on the what rate to give, what is the normal maintenance IVF rate for patients with dengue without warning signs being admitted and not being able to tolerate oral fluids. So, but however, if there is mild dehydration but no shock, then the maintenance IV fluid be added with fluids for mild dehydration. So, we compute for the total fluid requirement, which is equal to the maintenance IVF rate plus the fluids for mild dehydration, where volume for mild dehydration is computed as 50 ml per kilogram for infant and 30 ml per kilogram for child or adult. Then one half of the computed um, total fluid requirement is given in 8 hours and the remaining in the next 16 hours. So here is the formula showing total fluid requirement based on Halliday and Segar method. For example, in a in a 10 kilogram infant with dengue and mild dehydration without shock, based on the Halliday Segar method, the maintenance fluid is 100 ml multiplied by the body weight, which is 10 kilogram. And since this is an infant, so the mild dehydration is determined by multiplying 50 ml by 10 kilogram. And the sum of the products is the TFR, which is equal to 1,500 ml. The next step is to compute one half of the TFR, which is 750 ml. Sorry, there. So this is because one half of the total fluid requirement is given in the first 8 hours and the remaining half in the next remaining 16 hours. So as per computation, 750 ml should be given in the first 8 hours. So that is equal to a rate of 93 ml per hour, since the fluid requirement in the first 8 hours is 750 ml, then divided by 8, so it is 93 ml for 8 hours. Then for the next 16 hours, the remaining 750 ml is divided to 16, resulting to 46 ml per hour for the next 16 hours. The IVF rate may be decreased anytime as necessary based on clinical assessment. And if there is deterioration, then should be managed accordingly, whether for compensated or hypotensive shock which will be discussed in a while. So, it is indeed important to have periodic assessment for fluid adjustment and clinical parameters. The following are still the parameters to be monitored for admitted patients without warning signs. For in hospital patients, with having dengue with this time with warning signs, again, obtain a reference hematocrit before fluid therapy. Then give isotonic solutions such as the saline or Ringer's lactate, starting with 5 to 7 ml per kilogram for 1 to 2 hours, then 3 to 5 ml per kilogram for the next 2 to 4 hours, then reduce to 2 to 3 ml per kilogram or less according to clinical response. Then reassess the clinical status and repeat the hematocrit. If the hematocrit remains the same or rises only minimally, so just continue the same rate at 2 to 3 ml per kilogram per hour for another 2 to 4 hours. However, if there are worsening worsening of vital signs and rapidly rising hematocrit, increase the rate to 5 to 10 ml per kilogram per hour for 1 to 2 hours. Then reassess again the clinical status, repeat the hematocrit, and review fluid infusion rates, and give the minimum IVF volume required to maintain good perfusion and urine output of about 0.5 ml per kilogram per hour. So IVF fluids are usually needed for only 24 to 48 hours. Then reduce IVF gradually when the rate of plasma leakage decreases towards the end of the critical phase. This is indicated by urine output and oral fluid intake. And when it is adequate already, or when the hematocrit decreases below the baseline value in a stable patient. So monitoring for these patients include vital signs and peripheral perfusion every 1 to 4 hours until patient is out of critical phase. Also urine output every 4 to 6 hours, hematocrit before and after fluid replacement, then every could be assessed every 6 to 12 hours, and also the blood glucose, since diabetic patients suffering dengue are at risk for dengue shock, and other organ function parameters for renal, liver, and coagulation profile. Moving on to the management for severe dengue. So if compensated shock, so first is for the compensated shock. Start with isotonic crystalloid solutions at 5 to 10 ml per kilogram per hour over 1 hour. Then reassess if there is improvement, then gradually reduce as follows. So if there is improvement. But if still unstable, check the hematocrit, then repeat a second bolus of crystalloid solution at 10 to 20 ml per kilogram per hour for 1 hour. Then reduce accordingly. Further boluses may be given during the next 24 to 48 hours. So this is the algorithm for the treatment of compensated shock, which is already discussed. And for the compensated shock algorithm based on the CPG, especially for the pediatric population, the difference is the 5 to 10 10 to 15 ml per kilogram per hour over 1 hour in the first hour of resuscitation, compared to just 10 ml per kilogram per hour that in the DOH guidelines. So for the pediatric is 10 to 15. But they are common at the level of 10. So it's safe to give 10. But for those with severe dengue with hypotensive shock, so remember the table showing the stable condition, compensatory shock, and hypotensive shock. So check on those parameters that would point to hypotensive shock. So if the patient has Those then managed more vigorously, the fluid resuscitation starts at 20 ml per kilogram as bolus given over 15 minutes. If there is improvement, then sorry, then infusion at 10 ml per kilogram per hour for 1 hour. Then gradually reduce as follows. However, if the shock persists and hematocrit increases or remains very high, such as that of more than 50%, so change IVF to colloid solutions, then give at 10 to 20 ml per kilogram as second bolus over 30 minutes to 1 hour, and then reduce gradually as follows. But if shock persists and hematocrit decreases or less than 40% in children and adult females or less than 45% in adult males, this signals that there is bleeding and the need to cross match and transfuse blood as soon as possible is indicated. So further fluid boluses may need to be given during the next 24 hours. So these patients should be admitted in the ICU. Changes in the hematocrit are a useful guide to treatment. So it must be interpreted in parallel to the hemodynamic status of the patient, the clinical response to fluid therapy, and the acid base balance. So when there is increasing or persistently high hematocrit with unstable vital signs such as narrowing of the pulse pressure, it indicates active plasma leakage and there is a need for a further bolus of fluid replacement. While when there is increasing or persistently high hematocrit, but with stable hemodynamic status and adequate urine output, this means that extra intravenous fluid is no longer required. But when there is decreased hematocrit and with unstable vital signs, such as the narrowing of pulse pressure, tachycardia, metabolic acidosis, poor urine output, or hypotension. So this indicates the presence of a major hemorrhage and thus there is a need for urgent blood transfusion. But when there is decrease in hematocrit with stable hemodynamic status and adequate urine output, this indicates hemodilution or the reabsorption of extravasated fluids. So at this point, IV fluids must be discontinued immediately to avoid pulmonary edema. So this usually is appreciated during the recovery phase. So upon close monitoring, it is likely that hematocrit will start to fall within the next 24 hours as the plasma leakage stops. Indeed, close monitoring is even more necessary in severe dengue with the same parameters as other classifications. So we mentioned crystalloids in the fluid resuscitation in the management of dengue. So it includes the saline solutions, which is suitable for initial fluid resuscitation. However, for repeated large volumes of this 0.9% saline solution, it may lead to hyperchloremic acidosis and may aggravate prolonged shock or confuse with lactic acidosis. So when serum chloride exceeds normal range, so this is the normal range of the serum chloride, it is advisable to change to other alternatives such as Ringer's lactate already. So Ringer's lactate has lower sodium chloride contents. It may not be suitable for resuscitation of patients with severe hyponatremia. As mentioned earlier, it is suitable after 0.9% NaCl or saline has been given and the serum chloride level has exceeded the normal range. This should also be avoided in liver failure and patients taking metformin where lactate metabolism may be impaired. Then we also have the colloids. So as mentioned earlier, we changed to colloids from crystalloids, especially on those hypotensive shock, I think, not responding to the crystalloids. So here are the types of colloids: the gelatin-based, dextran-based, and starch-based solutions. And one of the biggest concerns regarding their use is their impact on coagulation. So the dextrans could bind to the von Willebrand factor or factor 8 complex and um, impair coagulation. Then also, this was not observed to have clinical significance in fluid resuscitation in dengue shock and can potentially cause an osmotic renal injury in hypovolemic patients. Moreover, gelatin has the least effect on coagulation among all the colloids, but the highest risk of allergic reactions. So, compared with crystalloids, colloids are associated with increased risk of allergic reactions and new bleeding manifestations, and it is more expensive. Although there is insufficient data to ascertain the advantage of one type of fluid in cases of severe dengue shock, the colloids may be used in patients who primarily present with hemodynamic instability and as rescue fluids in those whose cardiovascular status do not improve after the initial fluid resuscitation. So the use of inotropes such as epinephrine, norepinephrine, and dopamine should be started after adequate fluid volume has been administered already, yet the BP is still unstable. And finally, for the treatment guidelines, so for the treatment of hemorrhagic complications, so in patients with hemolytic conditions, they are at risk for acute hemolysis with hemoglobinuria, and they require blood transfusion. For mucosal bleeding, which may occur in any patient with dengue, and the patient remains stable with fluid resuscitation or replacement, it should just be considered as minor. So this usually improves rapidly during the recovery phase. For profound thrombocytopenia, ensures strict bed rest and protection from trauma to reduce the risk of bleeding. Prophylactic platelet transfusion for severe thrombocytopenia in otherwise hemodynamically stable patients are not necessary. It is important to note also that for these patients with thrombocytopenia, that they should not be given intramuscular injections to avoid hematoma. So it is essential to know who are at risk of major bleeding. These are patients with the following: prolonged refractory shock, hypotensive shock, renal or liver failure, with or without metabolic acidosis, pre-existing peptic ulcer disease, and any form of trauma, including intramuscular injection, and those given NSAIDs and anticoagulation therapy. The following are the signs to recognize when there is severe bleeding, persistent, um, with or without severe overt bleeding with unstable hemodynamic status, regardless of the hematocrit level, decrease in hematocrit after fluid resuscitation, with unstable hemodynamic status or refractory shock not responding to the fluid resuscitation, hypotensive shock with low or normal hematocrit, and persistent or worsening metabolic acidosis with or without a well-maintained systolic blood pressure, and especially in those with severe abdominal tenderness and distension. Upon recognizing those signs of severe bleeding, the next appropriate step is to give 5 to 10 ml per kilogram 5 to 10 ml per kilogram of fresh packed red blood cells, or 10 to 20 ml per kilogram of fresh whole blood at an appropriate rate, and observe the clinical response. So a good clinical response is when there is improving hemodynamic status and acid-base balance. So for the blood transfusion, the recommended are the fresh pack RBCs or the fresh whole blood. When we consider repeating the blood transfusion, so if there is further blood loss or no appropriate rise in hematocrit after blood transfusion, for the use of platelet concentrates and or fresh frozen plasma transfusion, there is little evidence to support the practice for severe bleeding, and however may be given judiciously. So however, it's not the first line for hemorrhagic complications. And even the platelet is not concentrate is not given just because the patient has thrombocytopenia, as stated here. No prophylactic platelet transfusion is not necessary. However, if the hematocrit is not readily available, so assessment of the improvement should be based on the assessment of the hemodynamic status of the patient, as shown in the following parameters. Then, for the discharge criteria, all of the following conditions must be present: no fever for 48 hours with improvement in clinical status in terms of general well-being, appetite, hemodynamic status, urine output, and there should be no respiratory distress. And there should also be increasing trend of platelet count, regardless what level of platelet count. So as long as the trend is increasing. And there is stable hematocrit without intravenous fluids. For the recommendations on the preventive measures, the latest CPG focus on the issue on the use of repellents. So among individuals at risk for dengue infection, so the DOH latest guidelines recommendations include being against the use of plant-based non-DEET extracts over the DEET repellents for the prevention of dengue, as well as that of IR3, 3535, and also of citronella. So for plant-based non-DEET extracts over DEET repellents, there is no significant difference in mean repellent activity and complete protection time. For the use of IR 3535 over DEET, studies shows no significant difference in mean repellent activity but has 1.5 hours less complete protection time. And for the use of citronella, there is also no significant difference in the mean repellent activity, but there is 3 hours less complete protection time. Here are the examples for the plant-based non-DEET repellents. So DEET is an ingredient of that one, the diethyl metatoluamide. So this is an example of the non-DEET. So usually the lemon eucalyptus oil and the IR 3535 extracts, or another name for ethyl butyl acetyl amino propionate. It is also an ingredient for repellent, and also the citronella based repellent. So an example of the DEET mosquito repellent is that of lotion, which is proven effective DEET mosquito repellent. So the elimination of dengue is the responsibility of everyone. The DOH continuously seeks the participation of communities in eliminating mosquitoes as well as their breeding sites. It is essential to focus on vector control and community education rather than making recommendations on using any type of insect repellent. So the following are not found in the DOH CPG. So actually, we are through with the CPG, DOH CPG guidelines. No, that was the one being asked from me to lecture on. But though it is not found in the DOH CPG, especially the latest one, which only emphasized new points not found in the previous, it is still important to know what are the ways to prevent and control dengue. And we can check on this from the WHO. So if you listen to the discussion on the background of dengue, then part of your education to the patient is to avoid getting further mosquito bites during the first week of illness. So at present, the main method to control or prevent the transmission of dengue virus is still to combat the mosquito vectors. This is achieved through the prevention of mosquito breeding sites, personal protection from mosquito bites, which include wearing clothing that minimizes skin exposure to mosquitoes, and also community engagement, reactive vector control, which includes applying insecticides, and active mosquito and virus surveillance. So this should be done regularly to really control um, the infection. So next is, of course, on vaccination against dengue. So the first dengue vaccine, the Dengvaxia, was developed by the Sanofi, licensed in December 2015, and has been approved by regulatory authorities in 20 countries actually. However, those who were seronegative at time of first vaccination had higher risk of more severe dengue and hospitalizations compared to unvaccinated participants. Hence, the use of vaccine is targeted only for persons with 9 to 45 years of age living in endemic areas who have at least one documented previous dengue virus infection. So this one is very important. So the recommended strategy then was the pre-vaccination screening for countries considering vaccination as part of their dengue control program. So only persons with evidence of a past dengue infection would be vaccinated. So there should be an antibody test or a well-documented laboratory confirmed dengue infection in the past. So the decisions about implementing pre-vaccination screening strategy require careful assessment at the country level, including the consideration of the sensitivity, specificity of available tests, and of local priorities, the dengue epidemiology, the hospitalization rates, and as well as the affordability of both the vaccine and the screening tests. So for the latest update on dengue vaccination, actually there are three vaccines to consider already. And the leading one as of 2025 is that of the Dengue by Takeda, where it shows protection up to 7 years and recommended for 6 to 16 years old who live in high transmission areas. It is a live attenuated tetravalent vaccine for to be given for 2 doses with 3 month interval, um, providing protection against the four serotypes, but contraindicated in pregnant and immunocompromised. Its use is approved in numerous countries, including the Philippines, but for regulatory evaluation still. A single dose vaccine, the Butantan DV, is also up with ongoing research. Its 5-year study showed 65% overall efficacy, approved in Brazil. Then the Vaxha, which is restricted, approved by US FDA, but only for 9 to 16 years old, especially when there is laboratory confirmed previous dengue infection, to be given 3 doses 6 months apart. And however, the European Medicine Agency and Commission ordered its withdrawal from marketing authorization due to commercial reason. And in the Philippines, as of this March 2026, Vaxha remains to be suspended following safety concerns. No? So also, the manufacturer, the Sanofi, has discontinued the production of the vaccine. And these are because of the 2017 to 2019 controversy, which involved legal cases against former officials in the Philippines, which severely impacted the public confidence in vaccination and resulted in a long-term ban, though local proceedings still continue. So all this, despite that the CDC still considers Dengvaxia actually as safe and effective only when administered specifically to those individuals with laboratory confirmed previous dengue infection. So I guess this is all you need to know for the vaccination for now. So the lecture on dengue fever CPG finally ends. So thank you for listening. I hope you learned something this afternoon. Are there any questions? Were there any interruption? I mean, was the presentation or the screen and audio clear? Are there any, do you have any questions? Talking to hear pala lang. Ano man yun? Chat. There. So someone asked, Kate Baltazar, Doc, in your clinical practice, are there many cases wherein your patients develop ITP? In my practice, actually, I haven't. In relation, is this in relation to dengue? So actually, in my since clerkship until to TGI ship to residency and fellowship training, I haven't encountered patients who had dengue fever who developed ITP. Okay. So thank you for that question. Are there any other questions? So I think we finished an hour before expected. So those actually 135 slides. So we just finish it in 2 hours. Yeah. Okay. Any other concerns? Were you able to follow the lecture? Um, So going once, going twice. So I hope you learned something this afternoon, and you'll have more of Doc, is it possible to ask for reference? Ah, yes, it is. Actually, yung ito, wait lang, asan siya? Wait lang. So basically, my references are from here. This one, clinical practice guideline on the diagnosis. So this is the latest approved by the DOH. So I included all the points emphasized, and I just pointed out what's the, and also I included this one since there are many of the previous guidelines that were not mentioned here. No? They only mentioned what is not being mentioned in the preview. So I um, fuse them. Then I just review, check what is the difference. So I think I mentioned before in the lecture, it was in the fluid resuscitation on compensated shock. So it is 10 ml per kilogram for the for in these guidelines. However, for the pediatric, it is 10 to 15. So that's the only siguro point that you should know at this time. Then also, you can check on the WHO for the background and also for the prevention, other other ways of prevention and control. See what else? I'll stop share. Are there any, so going another ones?
I think none so far, Doc.
Okay, so wala. Ay, this one na pa siya. Mm. Actually, based on the lecture, no, it was also seen. It was also mentioned during um, diagnosing the probable dengue. But sometimes, usually it is manifested during the recovery phase. But not not all recovery phase will also have Herman's rash. So sometimes it may be seen during the initial or the second phase. What's a really good na sign po Doc na more earlier detected na dengue besides history of mosquito bite? So actually, still no the the criteria for the probable dengue, the one with the patient should have history of living in endemic areas or history of travel, no, or any circumstances that has that allows the patient being exposed to um, mosquito bites, no, or traveling or maybe hiking, and then there are mosquito breeding sites in the areas, no. So and as well as, so it is a combination of that um, possible exposure plus the signs and symptoms of dengue fever, no, as the fever, of course, and the associated signs and symptoms being mentioned earlier, and then plus the investigation, the laboratory.
Thank you,
Oh,
madam.
mm-mm. So actually, I haven't um, experienced. Someone mentioned about ano, nag-private message lang siya. How to prepare the papaya leaves. So it's an in the guidelines it was mentioned as extract. So actually it wasn't not really mentioned how. So in the studies that is the gray area, no. That's why when you read on the CPG, they put low certainty of evidence, however strong recommendation by the DOH panel. So low certainty of evidence because there is gray area, no, on how it is being prepared, how many the volume, the exact volume of how it is being taken. So that was the gray area regarding on it. So I think it's an extract. So yeah, that's how you. I think that's how you will be able to make it a fluid, right? So from papaya leaves, yeah. Mm. So it was not really mentioned if it is blended or it is being boiled. But however, in our practice, in local experience, no, in the in areas na usually parang nagpa-practice ng mga yung mga ganyan, no, mga extract. So usually they usually do the boiling. But I haven't encountered someone doing the blended, especially for papaya leaves. Maybe for papaya. Have I answered your question? Katong nag-private message. I will not mention yun na lang ka nag-private or ba siya? Pero nag-ask siya na, sana, how to prepare the papaya leaves. Like pabukalan siya or gina-blend or extract. So sa guidelines, it was said na extract siya. And yun, usually kung I don't, I'm not sure how it tastes kung blended siya. Usually pabukalan, no, in when you go to remote areas or yung mga ganun in our setting as Filipino. Doc, it's not on the slides, pero will apple juice help po? I tried to check online, pero okay. Let me check, no. But I think I just wala siguro gid na ako na mention, pero it was dili ako ipakita because fruit juices can be given for oral rehydration. Wait lang. So I think it's here on the treatment guidelines for group A patients here. So milk fruit juice, but with caution with diabetes patient. So this is from the 2011, no? Because yung bagong DOH approved CPG was not really very detailed, no? So mas detailed ni siya nga guidelines. That's why I still got my source from this. But yung mga bago na gi-emphasize, I incorporate it. So yung mga bago is wala din hinga, wala sa previous na kuan. Okay. Okay. So I think since it's fruit juice, so I think the Mott's apple juice may be somehow okay, but we have to check um siguro their contents, if they would give us a low osmolarity. So it is still best to give the ORS, since we are very mas particular, we are very sure of the content and the level of content, that it will not be hyper osmolar, um which will ano yun, yung mas ma-dehydrate pa yung patient and will cause more plasma leakage. Sige. So what else? Mm. So that actually that answer was because of the question, nag-ask siya nga, will apple juice help? Then Mott's apple juice in particular. So that was my answer. Kaya nag-answer lang ko diretso. I thought makita ninyo tanan ang messages. Naka-private pala. So someone also asked, based on experience managing dengue, hemorrhagic fever, and dengue shock syndrome, do patients typically have a prior history of dengue infection, or can these severe forms occur purely as part of the disease progression? So both, no. Um, s- Based on reviews, no, usually those with second infection of another serotype will have severe dengue, most lang, but not all. And also, even though it is a primary infection, there could still be a progression of severe dengue. No, so there are other risks, no, aside from a second infection for a patient to develop severe dengue, such as having the comorbidities. So it can, yes, so both, no? So the answer for your question, si Bianca Estavas, can be both. So yeah, you're welcome. I think many of you are very interested in dengue. So someone has a private message. Doc, I encountered one doc, that would require 3 days old na pack RBC for blood transfusion every time. I'm not so sure, Doc, if exclusive lang to sa pag-manage niya with dengue patients, but will it significantly affect that management? What do you mean, 3 days? Bali, the pack RBC is already 3 days old na. Dili na siya. Fresh. So, according sa guidelines, di ba? I mentioned fresh pack, pack RBC or fresh whole blood. Maybe we can still use it if it depends on the expiration date. So, yan. Kasi the longer it is being stored, um, the longer it has the risk for allergic reaction. So, thus giving another problem, no, sa patient. Instead na dengue lang sana ang atong i-manage, kung ano noon, allergic reaction, or it could be anaphylaxis, no. So yeah, if ang sa guidelines, fresh pack RBC good. And sa allergy wise, katong dili naka-store very for a long time na, no, to avoid possible development of mga chemicals or toxins na makakause og allergic reactions that can be detrimental to the patient, no. So additional problem. Mm. Well, so far, someone asked if there are cases of mixed infection with chikungunya. How does the management change, if ever, doc? Actually, in my experience, I haven't encountered such, no. But if you encounter such, I think you should report it as case report. However, maybe we can look up into it, no. Baka nanay nag report on it, no. Chikungunya and dengue fever. But usually chikungunya is parang compared to dengue, mas very kuan ang management sa dengue, very detailed, particular, no, because of the risk, no, of developing dengue with warning signs or severe dengue. So that's why we are very more detailed in the management, or yun, if that is the correct description, no. Unlike sa chikungunya nga, parang less, ano siya, less toxic one. So usually, mawala, it will just be self-limiting, parang ganun. Oh, for that, someone asked for the tepid sponge. So is it whole body or focus on areas lang? So actually, it was not mentioned, but I think tepid sponge is whole body. No, wala siya na-mention particularly actually in the guidelines kung focus lang sa part of a body, but I think when we say tepid sponge, the whole body gina siya. Because when we say we do tepid sponge, it is because of the fever, and fever is a systemic, no, so it involves not just a local area of the body. So I think whole body siya. Sige, napaiwan niyo. Sige, go. Another private message. Basta private message, ilang ako ikuan. Mention yung name. Doc, is the outcome of the patient with severe dengue mainly depend on the body's response to the treatment, or is the doctor's judgment and management play a larger role for the patient's survival? Both pa rin, no? So, the outcome of the patient with severe dengue mainly depend, no, sa body's response to the treatment, as well as the doctor's judgment and management. So both play a role on the outcome of the infection. So yun, because the doctor's judgment and management is very important. However, there are factors, no, na sa patient mismo, no, that is very difficult, um, maybe difficult to treat, no, especially if there are complications. So it really depends somehow on, that's why some patients, no, even though without warning signs, katong mga pregnant or obese, no, or those living alone, no, not able to take care of themselves, should be admitted as ano, should be cared for in hospital management. Sige. I hope I answered your question. Um, Okay. Someone asked, or like, before the first question I answered. So would like to ask, is dengue suspected more in children here in the PH, or do we equally suspect it in adults as well? We equally suspect it in, since it affects infants and adults, no. So we equally suspect in both, no. Though I think there are more cases na children reported. Ano ba? TP. Will you be so kind to share us with your slides po, Doc? Sige. Does other lecturers share their slides?
Most, Doc.
Most, sige. How can I share my slide? Isend na ko diri, or na I email, or hello? Maybe I can send here through the message, no? I'll try. Mas-send man siguro. Then i-download na lang ninyo. Wait lang. Sige. Or I'll ask an email ad na lang ako isend. Okay lang ano? At sa mali.
Good afternoon, Doc. I think mas
Sige.
easier ang email.
Sige. Ako isend ani kay na nag-send kathyegam@gmail. Sige, ako isend sa iya ha. In a while after here. Nasa naman ito? Nasa naman ako? So, basta as long as you share it among yourselves lang ha, your batch, and
Thank you, Doc.
um, copy. Your batch and our institution. So that don't just share with anyone. Then, sige. So actually, I'm so excited sana to lecture this face to face, no? Because the first time that this was asked from me, no, or for me to teach this topic was last 2020. So initially for face to face gapon. Unta siya nga lecture, and then pandemic happened. So naging online per asynchronous. So at ngayon face to face sana, pero naging online na naman. So I think baka another lecturer should lecture this topic in the next time. So I
Hello,
will,
Doc.
yes.
Doc, for the exam ni Doc, will you get questions sa PPT ni mo, Doc?
Ano to? PowerPoint?
Yes, Doc, sa imong slides.
Yes.
Thank you.
Mostly, oo. So mag-review na lang mo. Pero akong I got that from the latest pod, yung mga sa DOH na guideline. So kato ra pod ang naa sa PowerPoint, more sad to ang points na at least you should kay basing taasan kay mo basa sa guidelines, no, with all the mga reviews and studies. So kato lang ang nasa akong PowerPoint are the points that you should know, no, or you must know.
Hey, thank you,
You should
Doc.
know. So medyo gi-filter na nako ang uban nga ano, you can read siguro if you have so much time. So I'll send in a while kay kathyegam@gmail.com. Sige. Then you can message lang me. Or I think someone has a number. I don't know. Minsan ba ito may number sa ako. Kung if ever wala pa ninyo na-receive within this day. So checking, are there other... So far, no other new questions. Be reviewing if wala ko'y nalaktawan. Okay. So I think before we call off the lecture time, should we have a screenshot for your attendance? Yung sa mga screenshot sa inyo. Kasing ipasend ba mo ni Doc Vince?
Ako ra screenshot.
Mag-screenshot po ko sa inyo.
Sige daw. Sorry.
Pero mag-screenshot po mo sa inyo ha, kay baka I think this is the way of attendance. That was the way before ga attendance ni online. So laking pandemic lecture kasi ako. Sige. So na screenshot man ninyo tanan yung classmates. So, ayan. Na group work. Okay na siya. Kung ma-absent gani mo, at least na yung face. Yun gini niyo si level coordinator na present jud ni. Okay. Yeah, 105 man sa tanan. Okay na mo guys.
Screenshot na, Doc. Thank you.
Sige. So, are there any questions, concerns? Should we call it a day or gusto pa mo mag-extend og another hour?